Good afternoon, everybody, and welcome to the Terminology Leading Practices stream of the SNOMED International, SNOMED CT Expo 2022. My name is Jane Miller, and I work in collaboration and clinical engagement at SNOMED International, and I'm moderating today's session. And I will start with an apology straight away. We are a few minutes late starting because we are just finding the video because Eugenia Rinaldi is actually online and it's been pre-recorded. She's unable to be joined by Caroline today, but so no pressure, Joe. Joe is sorting it out for us over there. That's why you need the techies. Just to say that all questions will be answered at the conclusion of the presentation. And for online attendees, and I haven't looked yet to see what's going on online, but we have the Q&A box to type the questions in, and on-site attendees, please use the microphone provided. Joe, where's the microphone? Do you know? Oh, it's at the front. I've got it. Right. I'll be running around. Now, are you ready, Joe, or not yet? Okay, so we will wait a couple of minutes. And my sincere apologies to Dr. Rinaldi on the online. I know she's there and she's been very patient. No pressure, Joe.
Downloading.
Okay, we're on our way. So I'm going to actually now start the introductions. And I'm very, very pleased to introduce Dr. Rinaldi from Charité University Medicine Berlin. And she will be presenting on how well do concepts relevant to COVID-19 contained in SNOMED CT's global patient set cover clinical study data of a pan-European COVID-19 cohort. And I'm hoping that we're ready to proceed. Are you ready to proceed? No. Okay. We do know we're nearly there, so that's fine. My apologies for bumbling over the title because it's making me nervous as well. Technologies is great. Humans. Okay. So are we ready? Okay. We're good to go. So we will hand over now.
From the Berlin Institute of Health, from the Charité University Hospital in Berlin, Germany. And today, together with my colleague Caroline Stellmach, we would like to present our work on how our concepts relevant to COVID-19 containing small patient sets cover clinical study data of a pan-European COVID-19 cohort. So we will start by introducing the ORCHESTRA project, which is where the COVID-19 data come from, and then we'll say a few words on the SNOMED small patient set, and then we will present our results and draw our conclusions and some recommendations. So the ORCHESTRA project. ORCHESTRA is a European-funded project which started at the end of 2020 with the objective to create a new pan-European cohort to rapidly advance the knowledge on the COVID-19 infection. And in particular, its aims are to collect data on different information categories to evaluate predictors of COVID-19 and sequelae by virus area and immune and function status, and to study the immune responses induced by vaccines in different populations, and study breakthrough infections, and also study genomics data together with clinical data to see if it's possible to develop disease severity indices. This is what the partnership looks like. So it's a lot of partners, 37, not only from Europe, but also Africa, India, and South Africa. And the coordinator is the University of Verona in Italy. So the idea is to collect data from all these different countries, and this data have been divided and 4 major cohorts have been identified. So we have the long-term sequelae, which is collecting data from existing and new studies with the purpose to study the psychological, clinical, and radiological effects of the SARS-CoV-2 infection. In the general population cohort is collecting data on from existing studies without selecting people with the infection or not, and but actually study also the effects of the preventive measures of the COVID-19. And then the 2 remaining cohorts focus on high-risk populations, such as fragile populations. So we're talking about pregnant women, children, or oncological patients, or organ transplant recipients, and the healthcare workers, who are at-risk professionals because they're like physicians, technicians, or nurses who've been who have a high exposure to the infection because of their work. And then we study the study focuses on occupational and non-occupational determinants of the infection. So how do we break all the data together? We need to establish their data. And so in order to do this, we need to harmonize data sets to enable integration of data across studies, and also to make them readable by machines. Because what happens is that there are a lot of studies about COVID-19, but what happens is that these studies are maybe different systems that do not communicate with each other. And data are stored in different proprietary formats, or maybe use local codes for different languages, like in our case, with so many different countries. So, and maybe even just the diagnosis like COVID-19 might be described in different ways that are readable by humans, but not by machines, as the same diagnosis. So for all these reasons, to make we need to harmonize data. And because our purpose is always to make to enhance the usability of scientific data and make research reproducible. So our task within the project was to take care of data harmonization and standardization. So really to make data fair. So we focused on the semantic interoperability of the data. And for this reason, we looked at all the CRFs, so at all the data elements that were being collected throughout the studies, and the questions and answers, and we mapped them to international standards. So of course, SNOMED CT was the first one we looked at because it's the most comprehensive terminology in healthcare, and most of the data were actually mapped to SNOMED CT. But law played also a very important role because with the laboratory measurements, but as well as topological scales or other indexes were usually mapped to the Lloyd terminology. And when it came to describing prescriptions that were being treatments that were being given to patients, and we used the ATC classification. And for pre-existing conditions or for new conditions, maybe detected at follow-up visit, we use the ICD-10 classification, whereas for the genomics related for very specific genomics data, then we use the SCI thesaurus. When no codes were available, then we submitted the request for new codes to be created by the COVID standard development organization. And here below you can see a link to a publication in Nature Digital Medicine where we explain our work in further detail. And this is a graphical representation of the way we mapped the data in Orchestra. And so we see that the majority, like we said, is mapped to SNOMED CT, but line is very also important because of the big portion of information relating to laboratory and genetics examinations. So within such a big partnership like Orchestra, we've seen that not all partners are actually SNOMED international members. For example, the coordinator of Italy and even Germany, where it became it's become a member too. So we looked at the global patient set, which doesn't require a license, but then we had to look at the coverage of global patient sets against the Orchestra data set, and Caroline will in a few minutes tell us more about this. And then the other possibility is to apply for a research license for the project, and that's what we did, and we successfully obtained for it. So this is a screenshot showing a little bit of our work. So for example, in the first column, we see that it's showing some of the variables that we received from the CRFs that were included in the study CRF. And in the second column, the standard code, we map the variables. So we see some SNOMED codes that we use to map the concepts expressed in those variables. And the third column shows the new variable IDs that we provided, which included the codes, the standard code that we mapped the variable to. So why did we do this? We did this because we wanted to unambiguously identify a variable, but also to identify the same variables, the variables that were being used across different studies. And by doing this, we found over 900 elements that were used in these two studies. And these elements we put in what we call the Orchestra's core data elements for COVID-19, in short ORCHESTRA, and which includes all these variable components, support questions and answers coded in semantic standards, and that were used in at least two studies. And this object actually can be now seen, and we published it on this link. This the article, which is a public platform that can be accessible by anybody, and that can be used as a starting point for new studies. So now I'll hand it over to Caroline for the global patient set.
Thank you. As Eugenia already described, we looked at the orchestra variables contained in the OCDEC and compared them to the available codes and SNOMED global patient set. Next slide. The SNOMED global patient set is a managed collection of already existing SNOMED CT reference sets, and of course it contains SNOMED concepts, and it comprises of the concept unique identifiers, the fully specified names, the preferred terms in English language, as well as the active and active status flag. However, what is not included are the information about relationship, attributes, hierarchy information, and historical versioning. As such, it is not a curated list of concepts. However, these concepts can be used at no cost, meaning that there's no requirement for having a SNOMED international license. This global patient set is released on an annual basis, always in September, and the first release was issued in 2019. And the goal of having this GPF is to, of course, support research projects and organizations in coding their patient health data, and thereby facilitating interoperability, especially in countries that are digitally less advanced, for which this can be a starting point. In terms of content, the GPS contains content across general and family practice areas, but also nursing and dentistry. And when it comes to informational domains, it covers on areas included in IHE, in International Patient Summary, and also DICOM. when it comes to the response to COVID-19, SNOMED International made the great decision to react very quickly and develop new COVID-related content in January of 2020, which was then included in an effective release in March of 2020. This was naturally to support the reporting and sharing of such healthcare information in an attempt to tackle the COVID pandemic worldwide. In the September version or September release in 2020, this also included content referring to social determinants of health in order to combat the social inequity that we can see. And in 2021, the release version also included further COVID-19 terms and vaccine-related information. Now, this brings me to our results. So, Eugenia already gave you a great overview of the ORCHESTRA, which is really the collection of orchestra variables, and we compared the codes used to represent those variables to the GPS. And what was used as the basis of this comparison was the version of the ORCHESTRA as of March this year, and the, at that time, most recent version of the global patient set, which was the September 21 version. And it included about 24,000 SNOMED CT concepts. When we look at the overall results, we can see that from the 305 SNOMED CT concepts used to code orchestra variables, about 68, almost 70% were actually part of the global patient set. And within that share of variables that were part of the GPS, if we look at it in terms of informational categories, which really are the instrument or the grouping used in the case report form, you can see that the great majority of concepts were actually ones that describe comorbidity and new medical events, and then also symptoms, but other informational areas which we clustered into visually. When we look at some examples of SNOMED concepts that were part of the GPS and used in orchestra, we can see that within the comorbidities and new medical events grouping, we have concepts like sleep apnea, pneumonia, and diabetes, so very common health issues. And if we look into the symptoms category, we find common COVID-19 symptoms such as dyspnea, loss of sense of smell and taste, as we would expect. Now, if we take the same analysis, let's look at it by semantic tag. So analyze the concepts used that are part of the global patient set with regards to their semantic tag. We can see that the great majority were, of course, disorders, and they described comorbidity. Then we had findings, especially for the symptoms category. We had a good proportion of procedures, but also scattered other concepts across organisms, substances, and qualifiers. Now, if we look at this in comparison to the composition of the global patient set in terms of semantic tag, we can see that it's actually very much corresponding, because there's a great amount of disorder concepts within the global patient set, great number of findings, concepts, and also procedures. So next, if we look at the SNOMED concepts that were not part of the global patient set, but used to quote orchestra clinical study variables, we see that within those are still a good amount of comorbidities and new medical events, but also these miscellaneous concepts. So when we dive into the miscellaneous, we have some examples. So some of them used in orchestra would be the date of death, the date of discharge, but also then the infection and qualifiers. So if the patient's weight was detected, we would have kilograms. And then in the first most prominent category, the comorbidities and new medical events section, we have other very significant comorbidities in the context of COVID-19. So ischemic stroke, kidney disease, which is a big risk factor, but then also infections and autoimmune disorder. Now, if we do the same kind of analysis that I mentioned before for the concepts that are not part of the GPS, but used in orchestra by semantic tag, we can see that there's a great number of them are procedures, but also findings and used for symptoms, and disorders, qualifiers, and many others. And this already brings us to our conclusion.
Yes, exactly. Thank you, Carolyn. So we looking at all the concepts that were the orchestral concepts that were not included in the GPS. We decided to create a list of them and send them to International for possible inclusion in the GPS to reach the COVID-19 specific information. And the codes that we see here in this slide are actually codes that are orchestra codes that the orchestra is using and that are now part of the GPS. It's considered COVID specific and therefore included in the GPS. Those with the asterisks are actually new codes that we submitted, for which we submitted a request and that are now SNOMED codes. For which codes have been created and are now part of the GPS. So we know that for other concepts that are not included in the GPS, there were very specific procedures and findings that probably could not be left to GPS because they were really not directly connected to COVID-19. But in general, we can say that the use of SNOMED CT has really enabled semantic interoperability within orchestra. And if we look at what Carolyn showed us, we see that the GPS was actually already covering almost 70% of the codes of the data elements that we have in orchestra. So this means that GPS is really supporting the sharing of coded data, also for projects where they are unable for some reasons to obtain SNOMED CT usage license.
And based on the analysis that we did think that this was such a successful use case for the GPS. And based on that, we would actually think it could be useful for other projects and very valuable if SNOMED International considered creating subsets of the GPS that might address some other very important areas of research, such as adding codes for other very impactful diseases and significant health threats so that they become available for use and establishing interoperability. And within the orchestra use case in specific, in terms of COVID-19 content, we found that adding concepts that describe personal protective equipment and also known comorbidities that represent risk factors for COVID-19 and severe disease could be helpful if they were added to the GPS. And this brings us to the conclusion of our presentation, and we would both thank you a lot for listening to us, and we're happy to take the questions.
Thank you. My thanks to both Caroline and Eugenia. Unfortunately, Caroline isn't available, but Eugenia is there. I am going to allow questions. I'm going to run over because we did start late. Does anyone on the floor? We haven't finished in here, so if you could come in quietly, that would be great. If you could, has anyone got any questions from the floor? Okay, I have one here. Eugenia, can you highlight how you chose the terminologies to code information in the orchestra project, since you did mention that you had used several terminologies and classifications to represent the data?
Yes, hello.
Yes, we can hear you.
Can you hear me?
Yes.
Good. So I was also trying to actually turn the video on, but it seems not possible. That's okay. So absolutely. So actually, we chose SNOMED CT for the majority of the concepts because it's so, of course, it's the more comprehensive one. But then when it came to specific laboratory examinations, then we picked LOINC. And sometimes actually we also left the possibility, or we also noted whenever more codes were available and were actually appropriate, we also noted them so that in the metadata they stayed all the way, they remain available. And then for diseases, we picked the ATC classification and ICD for, for the ICD for the diseases and ATC for the medication and treatments. For genetic tests, because some tests were really variant specific and where they were really new and we could not find them available. Some of them we found in NCI thesaurus, but some others we just had to apply for new ones. But this is basically the distribution that we used in the mapping of the concepts.
Okay, thank you very much. That's helpful. So I'm going to draw this session to a conclusion. My thank you to both Caroline and Eugenia for your contribution today, and we will be placing this online afterwards. And I will make sure that your slide is corrected, Eugenia. Thank you very much indeed.
Thank you, and of course, I'm happy to also to be contacted via email for any other possible questions. Thank you.
Thank you. Thank you.